our lecture today about the testicular tumor. You know that testicular tumor, like any other tumors, can be divided into benign and malignant. And in fact, benign tumor in the testis is rare. It's about 1% of all testicular tumor, and 99% of the testicular tumor are malignant. Testicular tumor make up about 1% of all malignant tumor, and it affects the young adult from 20 to 40 years when there is fluctuation of the testosterone level. And 90 to 95% of all testicular tumor are originate from the germ cell. It causes definitely morbidity and mortality like any other malignancy. In addition to that, it also causes psychological and fertility problem in young person. In the last few years, the survival in testicular tumor has been improved. And this improvement is due to better understanding of the nature of the disease and its pathogenesis, first, and secondly, due to the presence of reliable tumor marker, and third, in the development and the treatment by the cisplatin-based chemotherapy. In the cross-section of the testis, this can be divided into two parts. The seminiferous tubule, from which the spermatogenesis occur, and the stroma. The seminiferous tubule contain the spermatogoniae and supporting cell, which is Sertoli cell, and the stroma is mainly from Leydig cell, which is the origin of androgen. So the testis is an organ that can excrete exocrine and endocrine. It excretes exocrine, that is the sperms, and endocrine, the androgen. The epidemiology of testicular tumors, as I said, make about 1% of all malignant tumor. And there are 3 peaks incidence as far as the age is concerned. It occurs most commonly from 20 to 40 years of age, i.e. it's affecting the young adult male. And also it can be occur in less than 10 years in infantile type, and after 60 years, which is due to lymphoma usually. And it occurs in bilateral 2 to 3% of the cases can be presented bilaterally. Classification can be classified into primary, secondary, or paratesticular. From the testis, either primary neoplasm or secondary. The primary, either germ cell tumor originate from germ cell, or non-germ cell tumors originate from the stroma of the testis. The secondary is usually due to reticuloendothelial system, like lymphoma, which is involving elderly people, and can affect secondary metastasis, which is very rare, can affect even younger age group. Paratesticular tumor is the third type. The germinal neoplasm, as we said, it is either germ cell or non-germ cell. Germ cell also divided into seminomatous or non-seminomatous. The seminoma have 3 types: classic or typical seminoma, and anaplastic seminoma, and spermatocytic seminoma. Non-seminomatous, either embryonal cell carcinoma or teratoma. Teratoma can be mature or immature, and whenever it attains the maturity, it becomes less malignant. Choriocarcinoma also rare, it's about 1% of the testicular tumor, and the yolk sac tumor. Yolk sac tumor, in fact, is a derivative of embryonal cell carcinoma, which occur in children. The primary neoplasm of the testis continued. Now, the second type is non-germ neoplasm, which is, as I said to you, it's rare. It's about 5 to 10% of testicular tumor, which is originate from either Leydig cell or other gonadal stroma, also gonadoblastoma, and other miscellaneous type like adenocarcinoma of the retitestis and mesenchymal neoplasm, carcinoid, and adrenal rest tumors. All of these are rare. Secondary neoplasm of the testis, also rare, as I said to you, it's reticuloendothelial neoplasm, which occur after 50 years in male or 50 years. Paratesticular neoplasm, in fact, most of the paratesticular neoplasm are non-malignant, benign tumor, like adenomatoid, cystadenoma of epididymis, mesenchymal neoplasm, mesothelioma, or metastasis from other tumor. Etiology of testicular tumor, like any other malignancy, the cause is unknown, but there are predisposing factors like cryptorchidism and the same testis, carcinoma in situ, trauma, and atrophy. Testicular atrophy can be a cause for a malignant tumor. Cryptorchidism and testicular tumor. Risk of carcinoma developing in undescent testis is about 14 to 48 times the normal expected incidence. So there is high chance of malignancy in undescent testis. Cryptorchidism and testicular tumor. Why it become malignant? There are many factors. First and most important of them is abnormal germ cell morphology. It's dysgenetic testis. That's why it's not descent. The other factor, also elevated temperature in the abdomen and inguinal area, as opposed to scrotum. Scrotum about 1 to 2 degrees centigrade below the core body temperature. And also endocrine disturbance and gonadal dysgenesis. In fact, the most important part is the dysgenetic testis. That's why when we did an orchiopexy and we descend the testis down in the scrotum, still the chance of malignancy is not declining. However, the prognosis is better because it's become superficial and easily detected, can be followed and detected. Now we'll come to the seminoma. As I said to you, it's about 3 types, either classic or typical seminoma. Second is spermatocytic, and the third is anaplastic. The most common one is 85% of these all seminoma is the classic type or typical, and it occurs in the 4th decade of life. Microscopically monotonous sheath of large cell with a clear cytoplasm and densely staining nuclei are seen. Sensitio-trophoblastic elements are present in only 10 to 15% of the cases, and this leads to excretion of human chorionic gonadotrophin, which is tumor marker we'll discuss later. Embryonal cell carcinoma, 2 variants, embryonal cell carcinoma in adult or infantile. Infantile type called yolk sac tumor. This is part of the embryonal or derivative of embryonal cell carcinoma. When it occurs in infant less than and children less than 10 years, it's called yolk sac tumor. The third type is teratoma. Teratoma may be seen in adult and children also. They contain more than 1 germ cell in various stages of maturation and differentiation. Grossly, the tumor appear lobulated and contain variable size cyst filled with gelatinous or mucinous material. As I said to you, when it attains the maturity, it becomes less malignant. And it differs from teratoma of the ovary. Is usually teratoma of ovary is more mature. That's why most of them are benign. While in testis, because it is immature, that's why it contains undifferentiated primitive cell and it will be regarded as malignant. Choriocarcinoma is about less than 1%. Lesions tend to be small within the testis, usually demonstrate central hemorrhage or on gross inspection. Microscopically, it contains sensitio and pseudotrophoblasts must be visualized to diagnose histopathologically as choriocarcinoma. And they had metastasis usually to the pulmonary, to the lung, to the pulmonary metastasis, have pulmonary metastasis. Clinically, choriocarcinoma behave in an aggressive fashion characterized by early hematogenous spread. Paradoxically, small intratesticular lesion can be associated with widespread metastatic disease. Also, mixed cell type, it's about 40% of testicular tumor within mixed cell type. Most common is teratocarcinoma, about 25% of all testicular tumor, which are a combination of teratoma and embryonal cell carcinoma. Treatment of mixture testicular tumor, seminomatous germ cell tumor and non-seminoma, treated as non-seminomatous germ cell tumor. Carcinoma in situ occur in about 5% of the contralateral testes. If diagnosed, if we are doing orchiectomy for a patient with malignancy and biopsy from the other testes showing that the testes have carcinoma in situ, is usually treated by radiation therapy. Pattern of metastasis in testes, it's typical. The exception of choriocarcinoma demonstrate early hematogenous spread to the lung. Germ cell tumor typically spread in stepwise lymphatic fashion, and it usually going to the para-aortic lymph node, which extend from T1 to L4, but usually concentrated at the level of renal hilum because of their common embryologic origin of the kidney. Certain factor may alter the primary drainage of the testis neoplasm, which is either invasion of epididymis or spermatic cord, which may allow extension or spread into the external iliac or obturator lymph node. If there is scrotal violation, for example, if there is any surgery or biopsy, which is usually contraindicated via scrotal approach, because this change the lymphatic drainage. In addition to para-aortic, it may metastasize to the superficial inguinal or deep superficial and deep inguinal area, inguinal lymph node. Visceral metastasis may be seen in advanced disease, which can be metastasized to the lung, liver, brain, bone, or adrenal may also involved. Staging of testicular tumor, we use TNM staging. First is CIS or TIS, carcinoma in situ. If the tumor not spread beyond the testis, T1, not spread beyond the testis and epididymis. T2, tumor spread to blood vessel, lymphatic or tunica vaginalis, which is surrounding the testis. T3, if there's invasion of the spermatic cord. T4 is invasion of scrotum. TNM, as I said, N1 metastasis to single lymph node less than 2 cm. N2, single lymph node more than 2 cm, but less than 5 cm, or multiple node, all in collection less than 5 cm. N3, when there is at least one lymph node more than 5 cm. M, either M0 no metastasis or M1 distant metastasis. Only the testicular tumor in its staging at the tumor marker also to the staging of the testicular tumor. These tumor markers are lactic acid dehydrogenase, human chorionic gonadotrophin, and alpha fetoprotein. And according to their level, also it add to the staging, and they said S1, S2, S3 according to a tumor marker. Clinical finding. Usually patient presented with painless testicular swelling. In the most common presentation, the enlargement is usually gradually, usually firm and non-tender. Testicular heaviness is not unusual. The typical delay of treatment from initial recognition of the lesion by the patient to definitive therapy, which is usually orchiectomies, range from 3 to 6 months. The length of delay is correlate with the incidence of metastasis. As any other malignancy, if it is discovered early, then the treatment will be better, the result of the treatment, and the prognosis will be better than if it is delay in treatment and if it is metastasized beyond the organ. In fact, the testicular tumor, they said that tumor of 10%. What means 10%? 10% usually presented with acute testicular pain and acute epididymitis. 10% asymptomatic, related to metastasis like back pain, symptom related to metastasis like back pain due to retroperitoneal metastasis, or other symptoms include cough, dyspnea due to pulmonary metastasis, anorexia, nausea, vomiting due to retroduodenal metastasis, or bone pain due to skeletal metastasis, and lower extremity swelling if there is vena cava obstruction. So 10% is acute scrotum presented, 10% presented with metastasis, 10% are asymptomatic at the presentation and tumor discovered incidentally, and 5 to 10% tumor may be presented with hydrocele. And that's why in every patient with hydrocele, young patient, you have to do ultrasound to exclude underlying malignancy. Gynecomastia is rare in germ cell tumor. It's about 5% of all germ cell tumor, and it's 30 to 50% of non-germ cell tumor, Sertoli cell or Leydig cell tumor, because they are excreting hormone usually. It's very important that any patient with testicular tumor or all patients with solid, firm intratesticular mass that cannot be transilluminated should be regarded as malignant until proved otherwise. As I said to you, that in the diagnosis, we have to exclude serious disease. Why we have to exclude serious disease? Because they are life-threatening, first. Second, early detection will give better result in treatment and a better prognosis. So if delay in treatment, that may lead to metastasis. How we discover this? If we put in our mind that every solid testicular mass should be regarded as malignant until proved otherwise. The tumor marker is very important in all types of the tumor, but it is particularly important in carcinoma or tumor of the testis. The two main classes is onco-alpha substance, the alpha-fetoprotein, human chorionic gonadotrophin, and cellular enzyme, lactic acid dehydrogenase, and the placental alkaline phosphatase. Alpha-fetoprotein from trophoblastic cell, human chorionic gonadotrophin from syncytial trophoblast cell. Alpha-fetoprotein normal value is usually below 16 nanogram per ml. If raised alpha-fetoprotein is either in pure testicular tumor, either in pure embryonal carcinoma, teratocarcinoma, or yolk sac tumor, or combined tumor. Alpha-fetoprotein is never ever raised in pure seminoma. If there is seminoma and raised alpha-fetoprotein, you have to think about mixed tumor. Human chorionic gonadotrophin, its normal value less than 1 nanogram per ml. It's raised in all choriocarcinoma, 100% of choriocarcinoma, and 60% of embryonal carcinoma, 55% of teratocarcinoma, and 25% of yolk sac tumor, and 7% of seminoma. Rule of tumor marker help in diagnosis. 80 to 85% of testicular tumor have positive tumor marker. Most of non-seminoma have raised marker. Only 10 to 15% of non-seminoma have normal marker level. After orchiectomy and follow-up, so it's important in the diagnosis, important in follow-up, important in prognosis, and important in recurrence of the disease. After orchiectomy, if tumor marker elevated, mean residual disease. stage 2 or 3 disease. Elevation of marker after lymphadenectomy mean stage 3 disease. Degree of marker elevation appear to be directly proportionate to the tumor burden. Markers indicate histologic type of the tumor. If alpha fetoprotein elevated in seminoma, as I said to you, mean tumor has non-seminomatous element, i.e. mixed tumor. Negative tumor marker becoming positive on follow-up usually indicate recurrence of the tumor. Marker become positive earlier even than X-ray study. Imaging primary testicular tumor can be rapidly and accurately assessed by scrotal ultrasound because it is a superficial organ just beneath the skin. This technique can determine whether the mass is truly intratesticular, can be used to distinguish the tumor from epididymal pathology, may also facilitate testicular examination in the presence of hydrocele. Once the diagnosis is established by the treatment is by inguinal orchiectomy. After you are doing inguinal orchiectomy, chest X-ray and abdominal CT used to assess the two most common sites of metastasis spread, which is the lung and retroperitoneum. Differential diagnosis of testicular tumor, epididymoorchitis, and usually it is sudden and onset and have redness and usually associated with fever and urethral discharge, and the ultrasound can diagnose if there is mass or not. And hydrocele, and as I said to you that 5 to 10% of testicular tumor may be associated with hydrocele. So every patient with hydrocele should have ultrasound to exclude underlying malignancy. Other lesion in the testis like spermatocele, hematocele, granulomatous orchitis, especially the TB orchitis, can mimic the tumor. Treatment is inguinal exploration with cross-clamping of the spermatic cord and vasculature and delivery of the testis into the field. You see the mass. If you can do a biopsy at the same time if early, or you can, if there is suspicious and you have no facility to do frozen section biopsy after exploration and you see the definite mass, you have to do orchiectomy and then send according to the result of orchiectomy whether it is seminomatous or non-seminomatous, the following treatment. Seminomatous germ cell tumor is better prognosis because it's radiosensitive and chemosensitive, while non-seminomatous is usually only chemosensitive. There's an important point that scrotal approach and open testicular biopsy should be avoided in testicular tumor. Thank you very much for your listening.